Sorry for that. I think we are good to continue. Am I audible enough? Are you able to get me? Hello.
Hello.
Are you getting me clearly?
On my side, I'm hearing well.
Okay, thank you so much for feedback. If one is able to get me, then definitely all of us we may be in the same position. So yes, so we are discussing family planning this evening, and I was saying that family planning I think is one of the crucial topics that we just need to grasp as nations, focus on this because it is also a critical indicator in terms of how a nation is performing now. Family planning, by definition, is all about a decision which a couple or people that are married or an individual who could be in this relationship and not really committed to become what would term as husband and wife. And this decision is being made on how many children they would definitely want to have. And apart from that, there is also a decision that is made in terms of the frequency of these pregnancies. Now, when it comes to the history and trends of family planning, this is a general history that I bring before you. So, family planning has a long history which dates back to ancient societies where early humans used herbs, pessaries, and coitus interrupters to control fertility. And some of these things, even today, they are being practiced. Now, ancient Egyptians and Greeks documented various contraceptive methods. And by the way, the Western world, the Middle Ages, saw restrictions by the church. Even now, one church that is so strong in terms of restricting its members in the use of family planning are the Catholics. Okay. And despite this, despite us having this history, we can still see that these traditional methods, even today, they are utilized. So besides this, it's also important to take note that the issue of family planning did not just remain and developed and static, but with time passage, there have been so many um, developments, okay, establishment of specific clinics and organizations that eventually become so critical. And one of these organizations that has been key is the Planned Parenthood. So Planned Parenthood Association, it's an organization which originates from the USA. They are very key. They are working closely with marriage stops, and they have been providing these modern contraceptives since the 1970s. So after World War II, global concern about the rapid population growth led to international support for family planning. And we are now seeing even conferences being held, countries coming together and checking how best can these populations be moderated, because we understand even at home, if the numbers are fewer, the fewer resources that are available are well utilized. But if the numbers are growing, even the fewer resources cannot support everyone. So this was thought to be a problem, and the only way they could ensure that numbers are low, it was through the issue of family planning contraceptives. Now in Africa, traditional methods even up to now, withdrawal, prolonged breastfeeding, lactation amenorrhea, and herbal remedies have been used and are being used in place of modern contraception that is currently available. post-independence, we are seeing countries like Kenya, Tunisia, even other countries in the region, because of not having these contraceptives in a more organized manner, population or rapid population growth was noticed, which of course came with its own challenges. In 1994, so this is a meeting that gave birth to a lot of issues. The International Conference on Population and Development, ICPD, it emphasized on productive health and rights, leading African countries to integrate family planning into broader health services. Okay, like a supermarket. When you walk into a supermarket, you will find this shelf containing groceries. The next shelf is containing electrical appliances, and other shelf will see fruits. So in a similar way, there was integration of contraceptives. That's why today in our maternal child health centers, they will not just wear these babies or growth monitoring. They will not just look after these pregnant women antenatal, but they will also target these women who are pregnant. But one thing that is not well developed in Africa, it's the issue of pre-conception services. On this one, we are generally weak. And unfortunately, you will not see a lot establishments of pre-conception centers where if I want to plan a family with my wife, we would go there. We are cancelled. If the iron stores of my wife are low, she will be put on supplements and so on. So that's one thing that we are not doing very well. But family planning, it is something that has been institutionalized. Countries like Ethiopia, Rwanda, Nigeria, and Ghana implemented programs to improve contraceptive access. And this hence reduced maternal mortality. How? If this woman is not falling pregnant frequently, okay, she is trying to recover from the previous pregnancies, the issues to do with PPH and so on may not just be common, and thereby reducing the maternal mortality rates. And apart from this, what also came out strongly is the establishment of youth-friendly services. These youth-friendly services, at times, they are being offered in Zambia. They are called youth-friendly corners or spaces. Previously, it was called corner, but now they are spaces. And I know this is something that organization like UNFPA is championing across borders. And I know that even in other countries, this is there. Now, despite this progress, challenges still remained. And these challenges included cultural barriers. Others would not want to use this contraceptive. There is a lot of misconceptions around this. Others would say, if you are using family planning, there is cancer that may just set in. If you are using family planning, your blood is being stored somewhere and it's not being released at the end of the day. It will cause problems. So these were some of the challenges: lack of information, cultural barriers, limited rural access, funding constraints. Okay, but of course, African countries or African nations have continued to implement family planning initiatives, and this has really evolved. Any questions, or are we clear with the background so far?
On my side, everything clear.
Thank you.
What I can is
yes,
that
please.
even here in Rwanda, we have also those youth-friend services which provide some of family planning methods and counseling information.
Okay, that's good to hear. Julia, you are quiet. Is it clear? Julia?
Maybe she has connectivity issues.
Okay, so I saw from the chat that she's clear. Thank you. So let's go to principles of family planning. Principles of family planning. Principles of family planning. Principles of family planning. That's our next. Oh, she is indicating she has network issues. Sorry for that. So principles of family planning. Number one, treat each client well, interact, listen, learn, and respond to the client, and treat each client as an individual. The information that we are providing to this client, it's information that, of course, should take center stage of the reproductive cycle of this woman. If they are adolescents, we should choose appropriate information that we need to cover, give to them. If these are adults, that's just like that. Then apart from this, avoid overloading the client with information. I know one weakness that usually would be noticed that these women will be put in one room, and then this information is generally communicated to everyone across the room, not picking out even those who have not understood. And information sometimes is just too much. At the end of the day, they will just agree because they have seen their neighbors, they are using these methods. So provide the information the client wants. Okay, and this would come in later. For example, you have given your general talk, and then you are now profiling these clients. When they have gone into their categories or groups, that's when you can now tailor even more information to such a particular group. So help the client understand and remember the information given through the use of visual aids and reviewing of information. I know that all of us, we could have worked in these units, and at times we have counseling cards that we use. On the other end, the client is just seeing the pictures. On your end, you are able to read or relay information that is contained on that slide. So that's one effective way of doing it. Then apart from this, one thing that we need to adhere to is that these clients that we are targeting or giving information, they need basically 6 topics to be covered. 1, effectiveness of the contraceptives, the advantages and disadvantages of the contraceptives, the side effects and complications, how to use the method. Okay, the issue of sexually transmitted infection prevention, and the ABC, abstaining, being faithful to one partner, and also condomizing. Issues of behavioral change should also be stressed on. When to return? When should this woman come back for a review? Now, when we come now to family planning itself, beside the principles that we have looked at, we need now to embed counseling into the services that we are offering. We have so many types of counseling, but this one will borrow principles from the usual psychosocial etc. counseling into the context of family planning. So counseling becomes a vital part of family planning. Why? Because it will help the client to arrive at an informed decision. Okay, at an informed decision. Once you have given them options, it is known as an informed decision, because this client, rather, they are not even called patients, they are clients. This client will receive information on which they will make a decision from. Okay. So now, adequate counseling focuses on this individual's needs. Okay. Mainly, it will focus on them. Now, for you to provide individualized counseling, you need to subject these women to a process that is known as profiling. Okay, profiling is all about categorizing women according to their needs, and after which you provide information to all of them. So what is profiling? Profiling is a way of grouping clients according to their reproductive needs during a counseling session. Why are you doing this? Because you want to meet each individual's client's specific needs. Okay. Now, when we are discussing profiling, you can follow this flow chart. I know it may not so be clear, but I can read for you. From on the top, it says determine if the client is a single partner in a faithful relationship with one who is faithful. If they have indicated yes, secondly, you go on to say, is the client currently breastfeeding a child of less than 6 months of age? If the answer is yes, then you have profiled this client as a breastfeeder. Okay? Then besides that, you can also determine if the client, as his or her partner, wish to have more children. If the answer is yes, you will profile them again. So in short, profiling, it's all about categorizing these patients or clients, I don't know why I'm using the word patient, categorizing these clients who have come to access family planning in groups that will speak to their needs. Some of the questions that would pose, of course, I already spoke to them, is an issue to indicate whether this patient or client rather is single. If they are not single, you can further on ask, are they sexually active? And the reason why we are doing this, sometimes they can be on family planning, but again, you are also providing condoms so that this becomes dual protection from pregnancy and the STIs. Ask if the client is currently breastfeeding, okay? And by the way, when you're asking if they are currently breastfeeding, one important thing that we all know is that this woman who has a child who is 6 months less and they're exclusively breastfeeding, these ones, they can also receive family planning, but we are so much concerned with the hormones contained, especially in these contraceptives. There are some hormones which will come later on to know, which will suppress prolactin. Okay, this is a hormone that promotes the flow of breast milk. So what would happen is that if the client is 6 months or less, if they experience lactation amenorrhea, even better. But we have noticed sometimes this woman may be thinking they are not having these menses, but then others have even fallen pregnant. So according to the categories of these women, one category of profiling, or it's a group known as spacers or delayers. Spacers or delayers. What are spacers? These are clients who want to wait before having a first or another child. In our African context, this cannot just be appreciated, especially if this couple have just married. Okay, we have grandmothers who would want to see a bump develop on this woman, and so on. So spacers, they have been having children, and then they think, okay, it's time that we delayed from having the next. And then we have delayers. This, for example, could be prime. They have not even had a child, and then they so wish that they delay before the second child is conceived. And the recommended family planning methods would include condoms, the spermicides, the oral contraceptives, injectables, no planned scientific neutral family planning, intrauterine contraceptive device. These can work. Even other latest family planning method that we know. Okay. Then the other group is a group of clients who would be referred to as limiters. Remember, we are coming to these groupings after you have done your counseling, could be a group counseling, and then these individuals or clients are coming from there. So limiters, these are clients who do not wish to have any more children. Okay, they do not wish to have any more children, and usually these ones, they'll be subjected to long-term family planning methods, injectables, implants, vasectomy, and the BTL bilateral tubal ligation. So this could be done. The other grouping, it's a group of women that would be referred to as breastfeeders. So these are clients with a baby less than 6 months postpartumly. And for them, what would be recommended are condoms, female and male, spermicide. They can use mini pill. They can use, and the mini pills is progesterone only contraceptives, POCs, okay? And we know that estrogen definitely may just hinder the availability of prolactin, hence affecting this woman. So we want her to continue breastfeeding, but we also want her to be on family planning. Then apart from this, the other recommended methods would include lactation, amenorrhea. This one I think we know. Internal intrauterine contraceptive device, that is also usable. When we come to the fourth category, this is a category of those who would be referred to as having multiple partners. So they have several sexual partners, or who may suspect that their partners have several partners. So this could be a woman at home, married nicely to this man, and by the way, she just notices maybe my husband may just be having other partners. So multiple partners. One could be faithful, but the other partner is not. Meaning they are part of those who are several on the part of this partner who is not faithful. So the recommended family planning methods would include male and female condoms, abstinence. Okay. Dual methods are highly recommended. Double protection. You are protecting this woman from pregnancy, and you're also protecting them from STIs. Are we together up to this end?
Yes, we are together.
Thank you. Let's move on.
I have a question.
Yes, please. Yes, please.
Implant or implanon, where does it fall?
Okay, so the question is focusing on implants. Implants or implanon, where is it falling? And by the way, we know that these maybe to flash back where we're coming from. Yeah. So implanon, it can be used even for those who are limiters, okay, spacers or delayers. So it can fall on several, because at the end of the day, this is a woman who is not per se saying that she has stopped having children, but she may just want to delay having those children. So in terms of implanon, I think from my end, it can fall on several categories. Of course, maybe with an exception of where limiters, with an exception of limiters. On the others, she can. I'm not pretty sure of breastfeeding, but what is very critical is that some of these hormones, for example, implanon, should be combined. And at the end of the day, I think we may not either recommend it for breastfeeders, and also we may not just recommend this on limiters. So limiters, yes, they can use, but those who want to permanently just stop having these children, then definitely we cannot put it there. But for breastfeeders, we can eliminate it from there. I don't know if I've answered your question or I've just further confused you. And feedback.
It's clear, thank you.
Thank you so much. Principles of counseling in family planning. So on this one, we'll have Agnes. Can you read for us these slides?
Yes, is principles of counseling in family planning. Understand and respect clients' rights, earn their trust and encourage them to ask questions. Understand benefits and limitations of all available methods. Present complete and accurate information in unbiased, client-sensitive manner. Understand culture and emotional factors that may affect service provision or utilization by the woman or couple.
Thank you so much. Thank you. So, principles of counseling in family planning. I think this is just a repetition from where we are coming from. Have we been exposed to RMC, respective maternity care?
Sorry?
Have we been subjected or exposed to RMC, respective maternal care, maternity care?
Not yet.
Julia?
Maybe I don't get your question, but respectful maternity care is what is being encouraged now in the provision of services for the mothers.
Okay, so the question was, have we been exposed to that concept already?
Yes.
Okay, that's great. I think Agnes said no. And the first point actually speaks to that. Understand and respect clients' rights. So this is having, and by the way, there's an adjustment. It's not just RMC, but it is RMNC. The N is coming from neonatal. So I think these are things that are being adjusted, because I think all this time it's all about this mother. But the bigger question is, what are you doing for this neonate who is equally very vulnerable? So respective maternity care speaks to point number one. We need to understand and respect the rights of this woman. And unfortunately, sometimes we want to dictate which method we feel is best for this woman. Meanwhile, earlier on, we were saying this woman will make an informed decision after you have given her this information. But I don't know why we still feel, no, you just have to get this. Secondly, there is another thing that comes in. You are creating rapport. You earn their trust. And as you create this rapport, they will open up, they'll start asking questions, of which you need to provide even further information. Understand the benefits and the limitations of these available methods at your facility. Okay, present complete and, by the way, accurate information. There's a lot of misconception surrounding misconception surrounding family planning, but it is us who needs to correct it. Some of these things, just when you look at it, yes, it is true. And what the community is voicing could be the best, could be the truth, but based on the scientific evidences around, you will stand by that. So understand cultural and emotional factors that may affect service provision and utilization of these services. Culture every time plays a very important role. Don't be judgmental. Listen to the clients actively. Some of them will come with a lot of wrong information, and your job is to demystify. Understand the effects of non-verbal communication, even as you are concerned. Recognize your own insufficiency to effectively provide the service and refer. That's if you're unable. Now, the other thing that is also critical on the rights, we need to know that these clients have the right to refuse to practice family planning. They have the right to choose the method they find suitable. They have the right to privacy. They have the right to confidentiality and refuse any type of examination. And when this patient really presents themselves as such, I think you are at liberty as a provider to also not offer a service, because at the end of the day, why would you hand over something to someone whom you have not interacted with? Okay, so what is critical is how we proceed when we are in that session. And one thing that has been utilized severally, and even I think in other countries, is the acronym GATHER, GATHER. And each letter stands for one specific thing that we are expecting you as a provider could have done. So the G stands for greet. This is a patient who has come. Greet, okay? Greet them. Secondly, you are asking them what has made them to make a decision to come to your facility. You tell them, you start explaining, okay? Even as you are doing the helping, you are trying to just add more information, ensuring that they make an informed decision, explain even further, and then return, which is review. So gather is one of the best methods that we can use to just remember what we need to do whilst we are in this session. Now, I just want to also maybe indicate to you another very important thing that we can utilize as we offer these services to these our women. We have another acronym, CLEAR. So C stands for clear and simple language. That's why if there is a department, you would find a lot speaking vernacular. It is MCH department. So clear and simple language, important. Listen to what the client is saying. We have seen a situation where clients have been given this method. After a week or two, they come back in their multitudes because one, there are so many side effects, and others are blaming even this healthcare provider. And I know some of these things could have come with a donor hand in it. They want to achieve a certain milestone. I remember some time back, there was the insertion of IUCD. Every woman who delivers, they would put the copper T. At the end of the day, some of them are not even so prepared. They would come back with PID and so on. So clear and simple language. Listen to what the client is saying. Encourage and assure client of effective use of the method. Then ask for feedback from client and have the client repeat the key points. I don't know in our facilities if this could be very possible to ask each one of them to speak if they are clear or not. Then besides this, maybe just a question, are we clear? Are we clear on clear and gather?
Yes, very clear.
It's clear.
Thank you very much. Let's move on to quality of care in family planning. Okay. So quality of care is essential for maintaining the health and satisfaction of our clients. Very important concept, quality of care. It's a concept that ensures that our health services that are being offered to individuals and populations increase the likelihood of desired health outcomes. And they should be consistent with current professional knowledge. Even what I'm presenting right now, come tomorrow, definitely there won't be the correct things. I was just this week, Zambia was launching the malaria vaccine. I'm not sure if you are using the malaria vaccine. Julia, are you using the malaria vaccine in your country?
No, our country is malaria-free country.
Really? That's encouraging.
Oh, wow.
Agnes, are you using the malaria vaccine?
Not yet. We are using drugs only.
Okay. As we are in the equatorial region somehow, so this is something that we can't run away from. We have some
Julia,
Hello, Agnes.
hi. Hi.
It's like we have lost our facilitator.
But is it still on the platform? Is it still there? Maybe there is something which is
okay.
doing.
I'm here. Apologies. So quality of care. I was just trying to explain this concept. Quality of care. So as I was saying, it's a concept that stresses that our health services, the services that we're providing to individuals and populations, basically increase the likelihood of desired or positive health outcomes. And these services should be so consistent with what is currently being practiced globally. So these are standards that we're adopting. And apart from that, it also speaks to the issue of having the required professional knowledge, even as we care. These are as we care for our patients. So we are therefore ensuring that our services are of high quality, and they should include the following. Number one, providing and ensuring a wide range of methods. Okay, a wide range of methods will be ending in 4 minutes. Wide range of methods, including referral systems. That's important. It could not just do well. This vulnerable woman walks into your facility, and the only thing that you have are condoms, nothing else. And the quality of care demands that we need to have assorted different methods that are available. Okay, and all women and men, young people, should be provided with these methods when they have requested them for, as long as they meet the eligibility criteria. Secondly, quality of care also speaks to this very important concept, okay, of ensuring that the services that we are offering are very acceptable to the population and the client itself, and all clients should be treated with respect and dignity in a way that does not infringe upon the client's rights. I think for us at this level, we are real advocates for patient care that is offered in a dignified manner. I don't know why Africans were so cruel to fellow Africans. Just some few days ago, I was watching some videos coming from South Africa where they are chasing these Africans from their hospitals and so on. And at the back of my mind, I'm really failing to understand as to why we need to go to such extent of disrespecting this client. This woman goes to deliver. I don't know if you saw that video. She delivers from the car because she has been chased inside this facility. So she is outside Rebari, and the facility just a whole fence across. So personal biases also needs to be avoided and needs to be removed. Thirdly, quality of care emphasizes that they need to be effective counseling and provision of complete as well as accurate information about all the methods. That's why I think in your facilities where you could have practiced from, you would have this board where you stick all different types of methods. It is for a particular reason. We want to provide information in totality of methods that are available. This becomes a very important practice even as you are doing this counseling. So provide ultimate privacy as well as confidentiality. This at times could be a challenge. Physical privacy is basically not even attainable in some institutions because of the setup of our facilities. So auditory privacy also critical. But you would discover that you are counseling or having this session with a woman. Then on top there, it is so open. Even people that are outside are able to hear that, yes, there is someone with an STI inside there. So these are things that we need to advocate for, providing ultimate privacy as well as confidentiality. So if possible, separate rooms are provided or screens alternatively. But I think we should not fall back on the issue of use of screens. The client should only undress when necessary. The client should not be left undressed for a longer time. I think these are principles that we know very well. Then the other thing that will promote quality of care is the counseling skills and the technical skills which we need to possess. As service providers, we are community, service provider and community players are trained and given capacity on family planning updates. Very important. Very important. For example, the issue of implant did not just come now. It's not something that we can fall back on to say it has been there for a longer time. And by the way, we have this, it's an implant for 2 years. What do you call it? Implant for 2 years.
Here in Rwanda, we don't have 2 years. We have only for 3 years and 5 years. For 3 years, it is called Jader. And for 5 years, it is called no.
Julia, okay, great, Agnes.
Is the same as Rwanda.
I see. I think when I get it, I'll be able to share it even before the session ends. Okay, so let's move on. I think quality of care, I think demand that we have this skill. Yeah, but one thing that I've been noticed, especially when it comes to the insertion of the insertion of these implants, the IUCD, there are some of our counterparts who may not just have this technical know-how. So it's important that we adhere to updated protocols and also be at hand to give regular technical support and supervision. The other one principle that speaks to quality of care is providing convenient and accessible services that meet the needs of a client. I think the standard of WHO is that we need to have a health facility within 12-kilometer radius. This could be unattainable, especially in the rural areas where these women would walk distances and distances to find these facilities. But what could be important is also to use other initiatives. I know outreach can be done to distance places to offer this care to them in a safe and clean environment. Providing follow-up care is also just important. And if possible, I know that this could not be the usual practice, but where we have an opportunity, we need to get these clients receive even follow-up care in their homes. But of course, there are issues that would come in transportation and so on. So that's quality of care. And it is 2003. It is 2003. Tomorrow is our last session. So tomorrow, I'm asking way in advance that may, if possible, I think we can't start earlier than the required time. So we'll see how tomorrow would be in terms of how fast we can move with sessions. But I know that if you receive this presentation, you could have noticed that the presentation is going up to 100 and something slides. Not so much packed, but the other thing I think is just repetition. I urge each one of us tomorrow, I think, to come on time, to join on time, so that we cover the remaining portion of this presentation, and also we'll cover a presentation that has to do with medications that are used in midwifery. Do we have any questions at this moment? Any questions?